You ready?
We're ready.
All right, let's call to order the Clark County Veterans Advisory Board on this Thursday, July 8th, 2021 at 2 o'clock. So, do we have the flag, Sam?
Oh, yes.
If everybody would join us in the Pledge of Allegiance, please. All right. And go. I pledge allegiance
to the flag of the
United States of
America,
To the
and to
the
the
republic
republic
stands
which stands
one
one nation under God, indivisible,
liberty,
liberty and justice for all.
Awesome. Can someone do the honor of the invocation for us, please?
I will.
Okay.
This is Shannon. Sorry.
Thanks, Shannon.
Thank you. Lord, we just thank you for this time to get together, and we invite you into the conversation, into this process, because without you, nothing works anyway. And we thank you that you're in charge of all that we do. And we give you praise, honor, and glory in Jesus' holy name. Amen.
All right. Thank you very much, Shannon. Let's see. I'm going to do a roll call. There's somebody already have that.
I've got that, Madam Chair.
Okay.
All right. Roll call of all of our posts. 40 and 8, Morris Giesler. Alternate, Steve Sledgers.
Here.
American Legion Post 14, Gene Contour.
excused.
Dixie Hoteling alternate. American Legion Post 44, Richfield, Darren Wirtz. John Rose. American Legion 168, North County, no representation. American Legion Post 176, Salmon Creek, Michael Gibson. Les Schreiber.
Yes.
AMVETS Post 6, John Lovejoy. Vanis Pratt. DAV Chapter 4, Board Secretary Bruce Moss here, the alternate. Career Warpets 321, no representation. Marine Corps League 826, Steve Sledgers.
Here.
John Stoffel. VFW Post 4278, Shannon Roberts.
Present.
Dana Difford.
Excused.
VFW Post 7824, Board Vice Chair Michael Harding. Alternate Bruce Moss is here. VFW Post 12028, David Daly. Vietnam Vets Chapter 512, Greg Witzis. Nick Herbert. Members at Large, Board Secretary Kelly Jones.
I've been demoted, but okay. Here.
Board Secretary, excuse me, Board Vice Chair. Oh, I'm out of it today. Okay, members at large, Jim Jensen.
Here.
Michael Langsdorff. Kevin Lawson.
Here.
Brian McGillis.
Here.
Tanya Wart.
Here.
Clark County Representative Samantha Whitley.
Here.
And from our Veterans Assistance Center, Judy Russell.
Here.
Sharon Tyre.
Here.
And do we have any guests that are joining us today for our online meeting? Would you please state your name and who you represent?
Mallory Huerta, Disabled Veterans Outreach Program Specialist, Workforce Vancouver.
All right. Anyone else?
Tom Kuzno, Senior Vice Commander, DAV, Chapter 4.
Thank you for visiting us today, Tom. Is there anybody else?
Hey, Bruce, Michael Harding
Yes.
is here finally.
Oh, okay. Board Vice Chair Michael Harding is now here from 7824. Anybody else, please?
Nicole Peppers and Michelle Ahmed from Swatch.
All right. Thank you for joining us. We'll look forward to your presentation here momentarily. Anybody else? Final call. If not, Madam Chair, you have a quorum.
All right. Thank you, Bruce. All right. Next agenda item, the approval of the June 10th minutes, which you see on your screen. Are there any issues, concerns, changes, deletions, corrections, what have you? If not, I'll ask for a motion to approve as written.
Make approval of approve as written.
Second.
All right. All in favor?
Aye.
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 Any opposed?
That was Les Schreiber, and I believe Steve Sludges who said that. For person
Thanks,
second.
Got it.
Okay. No opposition, so approval of the minutes as written. And let's get right into it with Swatch.
Great. Should I share my screen?
Oh, sure.
Or you have a...
I just put together this brief little slide, but if you have something that you want to share, just go ahead. I think you can just do so. I don't.
Okay. Great. Okay. Everybody seen a slide presentation right now? No? It is giving me, let me go back to WebEx. It says share one screen at a time. I don't know what that means. Here, let me try again. Come on. I guess we can just go back to your slide.
It says we're viewing your screen, but it's just gray. So I don't know.
Yeah, when it gave me a message that it's better to show one screen at a time, and there we go. I see it. Let me try it again. Okay. Is it showing it now?
Yes.
There we go. So we were invited here today to talk about the Pathways program, but I did want to ground us in the Health Connect Hub first, before we go straight into Pathways. For those of you unfamiliar with the Health Connect Hub at Swatch, the Health Connect Hub is a community care coordination system for 3 counties in Southwest Washington, for Clark, Skamania, and Klickitat. And what a community care coordination system is a system that kind of organizes the work of community-based care coordinators throughout different agencies, and systems like healthcare or housing or education. The kinds of things it does is it helps to do the work of identifying and engaging patients or community members who need community-based care coordination. They screen community members for different risk factors, social determinants of health, and have the resources and knowledge to address those needs, so are able to navigate in the community. And they connect, do the care coordination. So they're connecting community members to the different community organizations who provide resources, and they follow up to make sure that the connections were successful, and that the intervention or activity were completed. And then lastly, they track all of these outcomes. So we have a platform called Care Coordination Systems that helps us to track all of the data, who we're serving and what kind of support we're providing. So that's what a community care coordination system kind of does. The kinds of things that make up a community care coordination system. Are you able to see my next slide?
Yes.
Okay, great, thanks. Is leadership. So we provide some leadership within the community to help organize, support, and GRIT funding for different care coordination, community-based care coordination activities. There's governance over issues like contracting, payment, deciding who we serve. We provide some adequate staffing. So because we partner with agencies, we're able to pool our staffing needs throughout the community to make sure that everybody can be served. We screen, we create care plans. We are, part of a network of community resources and partners working together. We make sure that the communication with clients or patients occurs and that there is a closed loop referral mechanism. So when somebody is referred to, let's say, a housing provider, make sure that that referral is responded to and that person is able to get their appointment. We also have ways in the system to be able to communicate with other partners and healthcare systems with interoperability functions. We engage in quality improvement for our community-based workers with continuous training and monitoring of performance. We also attempt to braid funding so that we can provide sustainable funding for our partners who do the work. And as we said before, data collection is an important part of what we do. It helps us to see how we're doing as well as identify gaps in the community. Are there any questions about a Health Connect, about a care coordination system? No, okay. So this is a slide that kind of illustrates how Swatch's Health Connect Hub is organized. We have 15 Health Connect integrated partner agencies who are either referral partners or work with us as care coordination agencies. We integrate 7 different care models. Pathways is our flagship, largest model, but we also have Care Connect Washington, which offers support for quarantine and isolation of COVID positive community members, access to health homes, humanic care coordination, community paramedicine, and we have some chronic disease, chronic pain, self-management programs. And to date, our Pathways program has initiated over 15,000 pathways. This is just a list of how our partner agencies work with us, what programs they help us with, and who they are, their area of expertise. I won't go through it right now, but we'll make the slides available to all of you if you want to look further. So now we can get into the Pathways model. So the Pathways community hub model itself creates an effective way for organizations to work toward common goals. Because it is a network of organizations, we partner with agencies. The common goal is to improve whole person health through care coordination, and we all work towards that. So why is something like a care coordination program important? I'm not sure if you've all seen this slide here, but oftentimes within the healthcare system, we focus on poor health outcomes. And you can see at the top of the glacier, we can see that maybe somebody's diabetes is not well managed or depression. And there are lots of underlying reasons that make it hard for somebody to improve their health outcomes. Where they live, how much money, their race and ethnicity, culture, their socioeconomic status, all of that is, what's lying underneath and causing some of those poor health outcomes. With the pathway strategy, what it seeks to do is find those community members who could utilize or gain benefit from a community-based care coordination program like Pathways. And we do that with a number of ways. Our community health workers or community-based workers are out in the community doing outreach. We have partners who refer to us, and we get calls from community members themselves who initiate contact with the program. And then they find who might benefit, they engage with the person and assess by screening for all kinds of social determinants of health and health issues, and then creating a care plan. And that's really done with Pathways through doing a comprehensive risk assessment. So somebody might be referred to us because they have housing issues, but a community-based worker would screen for everything to catch those underlying issues that might be leading to housing instability, such as employment or behavioral health. Based on what risks they find, they assign the pathways, and then they track how the progress of different pathways and mitigating different risks, and create connections to care. So the idea of Pathways and how it works is we identify what are modifiable risks. So things like food security, needing clothing, needing housing, parenting issues, health, depression, or substance use issues, access to healthcare, education, all those different risks. And then they go about working and supporting the person to mitigate some of these risks. So making sure they're connected to healthcare, or that they get housing established, or gain food security or employment. And then on the larger scale for a system and for the person, when we're able to meet some of those needs, it results in larger benefits like reduced hospitalizations, reduced cost of care, economic success and stability for the person being supported. So meeting those needs leads to greater outcomes. Now, this I think is what Samantha had on the agenda, and this is the list of the 20 standardized pathways. So we talked about the kind of the risks that we're searching for, and each of these pathways aligns with risks that we find, whether it's housing, health insurance, the need for referral to social service agencies, finding a medical home, going to the doctor, transportation, those kinds of things. One of the unique things about Pathways is they do come with an outcome. So there are 20 standard pathways, and each one represents a risk factor, and it's either achieved or if there was a reason it wasn't able to be achieved, then it's and so that's a finished pathway. the reason it wasn't able to be achieved is a finished and complete pathway. And there's different reasons for that. Lots of times, maybe a service isn't available, or the client didn't follow through, things like that. But whether a pathway is actually finished or not is tracked. And this is an example of a medical home pathway. So for a medical home, it would be initiated when a client doesn't have primary care, and then finished when they actually establish care with a primary care provider. The billing approach to pathways is also fairly unique. For payers and funders who are paying for pathways, most of the invoicing is for completed pathways. So we talked about there's complete pathways and incomplete pathways. We invoice for those that were successfully completed, not for those that weren't successfully completed. And then some of those invoice items are also tied to those completed assessments. So those assessments are lengthy, they're in depth, and we do reimburse for the community health worker taking the time to really get to know the person and use the assessment. So Pathways has a national certification. It's standardized. So all Pathways have nationally defined outcomes-based units, or OBUs. So they're similar to relative value units in Medicare, where each pathway is assigned a value based on how long it takes for a community health worker to complete, how much time it takes them, and the value to a community member. So an education pathway is just providing education about a subject. That's one OBU, whereas a housing pathway, as we know, obtaining reliable housing can take a very long time, and that, for example, is 9 OBUs. Is there any questions on that? No. Okay.
Not at this time.
No, okay. So some information about our Pathways program in general for Health Connect Hub. We serve anybody that's considered rising risk with complex conditions. So there's just multiple intersecting conditions, you know, between physical health, behavioral health, social needs, and for COVID-19 impacted. They tend to be very low income. 51% of the people we serve report an income less than $5,000, while another 20% report an income less than $10,000. 40% of Pathways clients are homeless, and 60% reported a housing concern. And nearly 2/3 reported a family crisis in the previous year. They also have a high health burden. So nearly 80% of our clients reported having at least 2 health conditions, with 60% having both a physical and behavioral health condition together. So the outcomes that we've generated so far is we have a pretty successful engagement rate. We had 77% engagement. We had 701 Pathways referrals so far, with 540 fully enrolled participants. We've initiated over 15,000 Pathways, and 10,000 of those were completed. 80% of those pathways are education and social service pathways. And we are independently evaluated. We have an evaluator who is evaluating for the effectiveness of our program right now. So we are, we do have some accountability to make sure this works. And this is just a slide for, just to let you know, it's not something we came up with. It's a nationally recognized model. It has several different endorsers. This model was originated out of Ohio, so you see several Ohio mentions here, but it's endorsed by CMS, CDC, HRSA. So lots of national recognition for this model. And that's all I have. Are there any questions?
I have one. This is Shannon with Post 4278. Back on slide 15, I believe it was, you were talking about the percentages of the homeless that had mental health issues and that had other health problems. Percentages are good, but what's the base number of people that were interviewed? Was it like 5,000 and then 20% of the 5,000 had mental health issues or other health factors? You see what I'm saying? I'm just looking for the base number.
Oh, sure. So those numbers are coming out of the 540 enrolled clients that we've served so far. So they all do risk assessments and answer questions around housing and health and behavioral health and access. And so based on their answer, their risk assessment answers, that's where the percentages are coming from. So 40% of the 540 clients that have enrolled were homeless.
Okay, awesome. Thank you.
Mm-hmm.
I have a quick question for you, Michelle. Does the Pathways program work within the VA also, or VA healthcare system?
It can. We currently don't have a VA healthcare, like a VA representative working, but certainly we've identified that expertise and knowledge of navigating VA resources and other veterans resources as a priority. And I think when we talked with Kelly and Samantha last time, we talked about some providing education and resources for our community health workers to better navigate those systems.
So Michelle, this is Kelly. Let's the slide where you talked about invoicing.
Mm-hmm.
So and when I watched the video that you guys sent, which was helpful, and then I plan to go watch the hour-plus training that the individual who created this did, because I think it's going to have a lot of really good information. So I'm just trying to wrap my head around on paying for this stuff. So when, like for housing, so in the video it said there might be 5 action items that were completed and 1 wasn't. Is that still considered an incomplete pathway, or each one of those steps a pathway? And are you billed based on the contact and the successfulness of each one of those steps?
So you're billed based on this completion down here.
Okay.
So sometimes you have steps here: obtain release of information, assist family in scheduling. Sometimes that step might get skipped. Let's say you talk to the person about needing a medical home and they take their own initiative to go schedule their own appointment. What you're paying for is still the need was identified and then it was actually completed.
Okay.
So that is the invoice point.
Okay.
That makes sense.
I got you.
Yeah. If 2 of these steps were completed but in the end it didn't result in a primary care provider appointment, then it's incomplete and it doesn't get invoiced.
That makes sense. Thank you.
Yeah.
Does anybody else have questions for Michelle or Nicole who are online? Yes, no?
This might be a stupid question. I don't want to be insulting Michelle, but if a navigator meets with a veteran and the veteran says, I need to make an appointment with the VA, and the navigator says, yeah, you should do that, and then the veteran does that, are we paying for that? I mean, I don't know. I don't know exactly. Are the needs identified by the veteran saying, I haven't been able to get an appointment, I really need help with getting an appointment, and so this is one of my needs? Or is it the navigator saying, hey, I recognize you have some health issues and I think you need to make an appointment?
It's both. It's supposed to be mostly community led, but the questions that come up on the assessment, and we can provide that for you, do ask, you know, have you been to the emergency room and haven't gone to see a doctor? Do you have a doctor? When's the last time you saw a doctor? You know, if they say, I'm still, you know, I'm on a waiting list or something to see a specialist, or they do tend to help. I mean, I can't think of they're not incentivized to sit back and wait and hope that it works out for them. They are incentivized to get it done, which often means supporting, helping them with the phone call, helping figure out who they need to call, you know. If they sat back and wait for everything, would have a lot fewer pathways actually completed. That makes
Michelle,
sense.
I have a question related to that. What if the veteran is waiting to be assigned a primary care doctor? Would that be considered a completion, or would it be considered incomplete?
It would be incomplete. So it's
If
not
they're
complete
waiting.
if they're waiting. It's not complete till that appointment happens.
Okay.
Yeah. And I would say that one of the benefits of tracking the data, let's say there's, you know, they're waiting for assignment of doctor, or we can see when the pathway was open. So when they identified that they needed a doctor and how long it took to close. So we can look at veterans and say, you know, for most people, they can get an appointment within 4 weeks to establish care. But with veterans, we're, you know, I'm not familiar with the timelines, but let's just say 3 months. There's a 3-month average, and just show what it takes.
It could be depending on any type of specialty care or what have you. So,
Yeah.
and so is there an average that you all strive to have these completed and closed out, or?
Yes. Yeah. So all these pathways usually come with an average of what we know it takes. So, you know, social service pathways, for example, usually get closed within 30 days. And if something's sitting there for 60, then we start bugging the community health worker. Yeah.
Well, I could see some of the other things being able to be done more timely, but when it comes to veterans health care, I'm not so sure that that's going to be a timely. I'm speaking from experience from somebody who uses the VA for 100% of my health care. I could be, and I don't have serious issues necessarily, so I guess that would be a concern is, wow, how long would that take to close out some of that stuff? So
Right. You do, I mean, that is one of the oddities of pathways is I mean, they do take time. A housing pathway can take over 12 months, you know. So while that's happening, that particular pathway isn't getting paid on, but there are easier to achieve things to work on. If somebody needs housing, for example, they might not have their ID, they might need to go fix their credit, they might do several applications. All of those generate tasks and activities for the community health worker to to work on with the community member to support that eventual permanent housing.
Okay, who's on from the center? Is it Sharon?
Both of us are.
Okay. Did you guys have a little bit more time to discuss this, and what do you think?
Well, I haven't had a chance to look at the video yet, which I'd like to do. Because I'm not sure I understand exactly how it works. And I mean, from what I see, you know, on the slides, it looks like it's like a step after step after step situation. But what concerns me is when our veterans try to get health care, right now it's I don't know that anybody's getting proper health care from the VA. Their doctors are only working in person 2 days a week. So I would like to look more into it myself. How do you feel, Sharon?
Yeah, I'd like to look at it a little bit more and get a chance. We had a meeting with vet court today, so we didn't get a chance to watch the video. So we would like to be able to watch the video before we could, you know, make any informed decisions.
Well, so I guess I'll say, Sharon, the video is only 3 minutes, and so it just kind of talks about exactly what Michelle just covered, but in very broad overview. What we had talked about in the meeting, when Judy wasn't able to be there, maybe I get that the Pathways program is really kind of targeted towards health and healthcare, which might not make as much sense for veterans and the VA, but I thought we were talking about maybe using this program is for veterans who continually come in and need support from the center. And the center, part of our policies say that for veterans who use a certain amount of assistance through the center, they will be required to do some kind of goal setting and case management, which the center doesn't really have time to do intensive case management with folks. So instead, those people could be referred to a Pathways coordinator who could then say, hey, it looks like you're not being able over this amount of time to become self-sufficient. Let's look at what things are going on with you and how we can help you. And we can take the time to go to the landlord with you, help you clean up your credit, call the credit agency with you, and really have a hands-on approach to getting folks not dependent on using the center's assistance and using public assistance. So maybe I feel like that we're kind of looking at the VA and the healthcare thing, which is not necessarily what this program would be best focused on as far as veterans are concerned, if that makes sense.
I see. Okay. Well,
Sure.
that makes sense. And unfortunately, I wasn't able to be at that meeting, so get the gist of that. But there are veterans that we have done self-sufficiency tests with, but not so much, you know, in the last 15 months because of COVID. But we certainly did some before that, anyone who used over a certain amount of assistance. And you're right, we don't have time to do it, especially now with the TRAP program on top of everything else. So yeah, it would be nice to have someone that could step in and kind of handhold, if you will. I mean, I know that's not really a good term, but it kind of is helping them in all areas. If they've used the assistance center over and over and over, and we don't have time to do self-sufficiency on them, it would be great to have someone that could do that. So.
I do want to, just mention it is care coordination is derived from the healthcare system or the idea of it, but it really does focus on addressing all social needs, regardless of their health needs. So it doesn't have to be somebody with high complex health needs. It could be just lots of, it focuses on whole person health, which oftentimes has very little to do with actual health status and more to do with socioeconomic status, race, education, that kind of thing.
Right.
Yeah.
Something else I know, like going back to your point that, sometimes it can take, X amount of months to get care within like a medical system like the VA. But I think also part of this program is that it centers the community-based workforce or community health workers. So while the time length for getting a medical appointment, for example, may not change, they also have a community health worker that is also staying aware of, that X amount of period until their primary care appointment happens, that they're following up with them to make sure that they, have transportation to get there and that the appointment is successful. So it's kind of that, just that idea that you're not going it alone. And while we may not be able to change the time length for care through the VA or accessing housing through VHA, that there's these additional community supports that are centered on the client for their whole person care.
Right. Yeah, and I think that would be helpful for a lot of our veterans to have that assistance in all areas. The fact that it's not just health based, but it's all areas. I think that's a good thing. So yeah, we certainly could a hand there.
And we don't need to make the decision today if we still want to have more discussion or conversation about it. But since it's only paying for the results, and since we have additional funding available right now, it seems like an opportune time to pilot this program in partnership with the Assistance Center and see if it's just, hey, we got a bunch of people piled up that are still waiting for VA appointments and nothing has changed. Well, it's very low cost to us, and we figure out that this isn't something that we can use or need, and then we'll know.
Okay, this is Darren Works from Post 44. How much of this is just kind of a extending the reach and the capabilities of our service officers?
What? I'm not exactly sure what you mean. The service officers don't set up any health appointments or arrange for housing or anything like that. So if you're talking about the service officers that do disability claims, that's basically all they do is disability claims.
Well, disability is one aspect of the service officers, but general assistance for veterans in need, a lot of it, the housing and stuff is referred. It would be referred to these folks, I guess. I just think it would be interesting to see just how much this costs, and like was said, what kind of an effectiveness it has in reducing the backlog that we're experiencing.
Well, I agree, Darren. But I mean, this is case management, and the center is not equipped or staffed to do that. The VSOs are not involved in that. My opinion is the harder cases, like the ones that continually, come in and use the fund or have financial difficulties or some behavioral health issues or whatever. I mean, that's where this program with their pathways will hopefully, be able to help us take on those harder cases and be able to get those veterans some help, because again, VSOs in the center are not set up or equipped or trained in most cases to deal with this kind of stuff. So I'm of the opinion, just kind of like Sam said, I think we ought to run it as a pilot program and Judy and Sharon in the center would certainly be able to, identify the tougher cases to be able to pursue this and then, see where it takes us. I mean, it can't hurt, right? So we're always looking for other resources, and case management is something that's always come up as long as I've been a member on this board. And let's just take financial stuff. I mean, people with lower income don't manage their finances very well. So, is there help there to help them do that? We don't have a financial, advisor or whatever, rep in the center. So, I mean, that could be done elsewhere so that maybe they don't have to continually come back in and tap the center for stuff like that. Let's get them some education and some resources to, teach them how to do that kind of stuff. So, case management it's lengthy. And this is, why the example that Michelle showed. I mean, there's a lot of little moving pieces to this. So I'm of the opinion that the pilot program sounds like a great idea. I mean, I'd like the center to discuss it a little more and kind of think about what kind of cases they've seen in the past and kind of come up with a plan on whether we can do this as a pilot program or not. What do you guys think about that?
This is Mike Gibson, Post 76. I have a question about this, and I'm wondering, would this actually fall under the purview of the intent of what this fund is to be used for? And I would wondering if the county would like to answer that.
Sure. Well, the way we had discussed it is that it would only be veterans that are referred through the center. So all of those veterans would already be screened for eligibility with the fund use. And so anything to assist those veterans in getting them more self-sufficient or into housing or into medical care would be an eligible use of the fund.
And
who do the screening, Sam?
The screening is, well, the veterans are screened by the assistance center for assistance and eligibility for the fund, and then they would be referred to the navigator who would do their own screening as far as what would the needs, all the comprehensive needs.
So you're saying they would have to pass our screening process in order to be referred to Swatch?
Correct.
And we have quite a few veterans in the past. I mean, in the last 15 months, we haven't because we weren't seeing them face to face. But we definitely had quite a few veterans that we had to do self-sufficiency tests on or self-sufficiency paperwork. And that paperwork takes hours to sit down with the veteran and go over each and every category of their life and where they need help. And so this program, if they cover all aspects and not just the health aspect, then that would be great to have some help in that respect.
I second what Sharon said. With our caseload, I know this isn't directly, connected to us, but I could definitely send people down there, get them screened and send them down to CVAC. Yeah, this would be a tremendous help, I think, for our people who really can't seem to get up and running by themselves. Absolutely.
Well, I believe this would be beneficial if we go from the aspect of a pilot program and have the two entities, the Swatch and the Assistance Center, work together to identify those veterans that are in need of that type of assistance, because it would relieve, it would better serve the veterans that require that extra attention. So I just think it would be of great benefit.
So Samantha, Judy, Sharon, want to discuss this a little more or what?
Well, I think as a pilot program, I think we should give it a shot. I mean, if nothing is accomplished, then nothing's going to be paid, right?
Right.
So therefore, let's give it a chance as a pilot program, and let's look at it in 6 months and see where we are and how many people we've referred, because I can think, Sharon and I are just saying, we can think of at least 3 people right now that could benefit from this program. 3 veterans.
At least.
So, I'm sorry, I was under the misguided impression that it was for health only, and I didn't get that it was all categories. So I apologize for that. But after realizing that it's all encompassing, I think that would certainly help.
Yeah, well, you have the 20 pathways to consider, and that does cover a lot. So I'm in agreement, and I think, you know, others who have spoken up, if we run it as a pilot program and see, you know, what it gets us and how it helps our veterans, and then revisit it at a certain point and, you know, go from there. Because we also don't want to place too many burdens on the community health workers if they can't ever complete a pathway. That certainly doesn't help them either. So, you know, we want to go in this with good intentions for everybody all the way around. So I'm open to, you know, if everybody wants to try a pilot program, we could discuss that today, or we could let everybody think about it, let the center think about it some more, or what. I'm open to it all.
What would be considered a success? I think we have to define that. What would be a success? Because Judy just said they have 3 veterans that they can think of off the top of their head. So what if those are the only 3 veterans that are assisted over the 6 months? You know, just for example, even though I understand that the need may be greater, but are we going to define what we anticipate or what we expect?
Well, I mean, success is a completed pathway, right? So even if we do 3 veterans in 6 months, that's 3 veterans that have been helped and got the help that they needed, that the center wasn't able to do by themselves because they're not staffed and resourced correctly to do that. So, I mean, you know, I don't know that you can really come up with a number and say that, you know, we do 10 veterans a year, that's success. I mean, I wouldn't hamstring us to that, because as the center is opening back up and seeing people face to face, you know, again, I mean, you know, that takes time for them to determine who would be eligible for this program, or not be eligible, but, you know, be a good fit for this program. So, I mean, Judy or Sharon, if you want to weigh in on that, but I don't know that you could come up with a number, Mike. I mean, I see where you're going with it, but, you know, this process takes time, especially as it relates to certain pathways. So this one veteran could take up to 6 months just on their pathway alone. The other 2 could finish in 30 days. You just never know.
Plus,
and how is billing determined?
We only pay for the ones that they have a success with, right?
Correct.
Okay.
And you know, there's definitely more than 3 people that we could that could use this program.
I have a question.
I have a question here. Can somebody else ask a question?
Yes. How is the billing determined? Did you hear that?
Yes.
Yeah.
Michelle, you want to field that one?
Sure. We talked about it briefly, but the billing, each pathway is worth a different amount, because it doesn't take the same amount of work per path, you know, for each of the different kinds of pathways to complete that pathway. But once the pathway is considered successfully completed, the community health worker and the agency invoice us. So each pathway actually represents its own invoice. The other thing that they do get paid for are doing those risk assessments, because those take time. But so the completion of the pathway is how the billing is determined. We at the hub review the pathway, especially those larger ones, to make sure that they've actually successfully did it or checked in with the person, that they were housed for 30 days.
So what you're saying is two different people could be charged different funding for the exact same completed pathway.
No. Are you talking about the braiding of funding?
I'm just wondering how you determine how much is charged for a completed pathway. Is it a set price, or is it determined by the number of hours you spend on one person, that pathway?
The pathway is a set price. It's a set outcome based unit, the price on it.
Regardless whether it takes a day or a month to complete, right?
Correct.
Okay.
The price is set by, I guess, determining or the valuing how much time it might take for the pathway to get complete. So a housing pathway is worth more because it typically takes more time and energy, where referring somebody to a food bank is not worth nearly as much because it's a much simpler task.
So do you have a payment schedule for each pathway?
We do.
Oh, maybe we need to see that.
I have a quick question. This is Mallory. I'm over here at Workforce Vancouver. If a veteran has multiple risk factors and ends up in multiple pathways, I mean, that's in theory, that's what could happen here. If there are multiple risk factors.
Yes, there typically are.
Okay, right, understood. So there would be more than, right, just the housing pathway. It could be 3 or 4 different pathways, or it could be 7 pathways or 1 pathway.
Yeah, everybody is, every community member is different. So some have higher needs, some have lower needs. And so one thing about pathways is that it doesn't have a time limit. Because it's paid for per path, for the agency doing the work per pathway rather than a set price per client or something like that, they are reimbursed, for that more complicated person, or that less complicated person, because maybe somebody has 1 pathway or 2 and another person has 10, and they continue to work with them, through those pathways.
Just another kind of question. Don't want to get in the weeds too much, but if you have a certain completion rate with your pathways, say 66% or so, and we were doing this test for this program, how would we budget for? Would we just plan on X number of pathways starting and then funding 66% of that at the end of the budget period, or how would you propose that we set up decent planning for this program?
We do have an average of what it costs for a typically engaged person, and it's about $2,300. Some cost more, some cost less, but that is about the average. Over a 6-month to 9-month period, usually.
So you guys might see on the slide, I had put in 30,000. That was just an estimate that when we talked with Swatch earlier, that he said that might be a good starting point for a year's program. But if somebody is if we just decide at the end of the year, we're done with this and we're not going to continue, there's somebody that's already had their housing pathway initiated, and we say, okay, program's over. Swatch will keep working with them, and because of their different funding sources, they're not going to drop that person off the program. They're still going to continue to work that pathway to get that person's successful completion at the if that person wants to continue working it and getting their housing, for example. And so nobody would be just dropped when and if we decided to stop doing it.
Okay,
And
so
then
for instance,
30,000. Go ahead.
so for instance, if you contacted a homeless vet, you found them housing, and you say that's completed, what's your determination on that completion? Would it be if he stays in the home for 30 days or 30 months?
Oh, sorry, Mike. Maybe you can't see the screen, but the one that I pulled up, the one that I was most interested in was the housing pathway. So first step is the initiation. They mark that. Then they say why they need housing. Then they partner to make sure to get the person in contact with housing organizations and schedule an appointment, make sure the client has their documentation together, has childcare arranged, has transportation to the appointment. They make sure that the client keeps the appointment with the housing and who they talk to. And then the healthcare or the navigator follows up with the housing person every other week to see where they're at and monitor the progress. And then they don't, after all that work, that only counts as a completion of the pathway if the client or family has moved into an affordable, suitable housing unit for a minimum of 2 months. And then they would finish this whole path and submit it for payment.
Got it. Thank you.
Okay, if the average is 23 or 2,300 per person, would our test be limited, say, to a year? And I thought I heard 30,000 out there. That's 12 or 13 individuals. So would we word it, say, a dozen individuals dealt with, and then not to exceed $30,000 for the budget period?
Well, what I would think, and it's up to the board, but I would not put a number of people on it. I would say up to $30,000. And if we approach, if Judy and Sharon refer 50 people the first week, and then in 3 months we've been billed $20,000, we would bring this conversation back to the board and say we're nearing the end of our funding limit that we established. Do we want to proceed? Do we want to fund it more? Do we? And you'll be every month when I get the invoices, I'll, or however Swatch will send the reporting, I'll share that with the board so we can track where we're at, what the expenses are, who's being helped, and what they're being helped with. Well, we won't know who, but I mean, the number of people being helped.
So this is Shannon. May I ask what the concern is here?
Are you asking me?
No, I'm asking the person that's asking the questions here. I think having this pilot project for 6 months, as was mentioned previously, would definitely be a good way to go. I'm sure there will be some bugs along the way, and we can iron those out. We can also see how much it costs per person in real time. There's going to be some things that need to be worked on, but I think it is a great program, and it will benefit the veterans that are currently falling through the crack. And I have a question concerning Gold Star mothers. Are we able to do anything for Gold Star mothers at all? Do you know?
There is an allowance through our policies for widows, but not necessarily for mothers. So we could make an exception if they were eligible as far as income wise and needed this type of assistance, I think the center could arrange that, because I think there's very few people that I know of in Clark County that are Gold Star mothers, but they're not currently eligible.
Excuse me?
They're not currently eligible the way we have it set up.
Well, Sharon knows what I'm talking about. I did have a Gold Star mother, and no one anywhere was able to help her. And I'm just kind of, she's living in a house that has no windows, basically, all broken out, no heat this past winter, and nobody can help her. So
I don't know. Oh, sorry.
Go ahead. I'm sorry.
I don't know if you've reached out to CMAC, but that's a huge focus for us, is the Gold Star family. So if you could give me the contact information, I would certainly problem solve her issues in that committee, if that's okay.
And this is you, Sam?
Yes, sorry.
Okay, I can do that.
Yeah, this is Brian.
Is that person that was asking. I'm sorry.
No, go
This
ahead.
is that person that was asking the questions that, you know, I think if you'd listened to what I'd said, I wasn't against the program. What I was trying to do was be fiscally responsible and oversee the budget that we have by setting some parameters for the program. So please understand that that was my intent. I wasn't denigrating the program at all.
And I was just asking what the concern was. So it's not like, I mean.
And so you have the concern, which is good business.
Yeah, well, I'm not going to argue about it on this venue. I'm just trying to ask a question here. So, Sam, I will send you her information, and I'm sure she'll be very happy to get some assistance. Thank you.
From a policy perspective, not to take us down a rabbit hole, because this deviates from the swatch presentation here, but just on if you look at the WAC, it's actually, the intent is for assisting veterans and their families and the families of deceased veterans, and it does say families, not specific to widow, widower. So maybe something we do want to take up in policy as far as Gold Star families.
Great.
Thanks, Brian. I'll look into that some more and have some more information for next month's meeting about expanding our policies to make sure that those families can be included.
Are there any other questions? If not, I guess I go back to, if everybody wants to take some more time to think about this, we can certainly vote on it next month. But I would ask that you do your due diligence in researching it more so that we don't come to August and some of the same questions are being asked that have already been answered, or we can go ahead and make the decision today.
Well, Madam Chair, this is just my take. I think there's a lot of veterans out there that need help and that have not received the adequate help that they need due to COVID restrictions that our society has been placed under. So I would like to suggest that this is something that we authorize right now, because as people get used to services being open, the more likely they are to find the assistance center. And so I just think it'd be to the benefit of the veterans if we open something like this up for them to take advantage of, versus waiting a month, because this is, after all, just a pilot program. This is not something that is permanent as of right now. So I'd like to see this as something that we begin right away, and help as many veterans as we can, because as I stated earlier, a lot of veterans have been without some assistance for quite a while due to the COVID restrictions. That's just my take on it.
Madam Chairman, just to get it on the table, I'd go ahead and move that we institute a 6-month test or trial program with a fiscal limitation of $30,000 and review after that time.
All right.
This is Mike Gibson, Post 176. I would second that motion.
All right, everybody in favor?
Aye.
Aye.
Anybody opposed?
Aye.
Nope. All right, motion passed. You got all that, Samantha?
Yep.
Okay. All right, Michelle, Nicole, thank you very much for hanging in there with us. We're excited to figure this all out and see what we can do. And hopefully it'll be something that will work out spectacularly. And then we can continue with it to help the center out. Because again, case management is something that they've long since struggled with because there's only so many of them to go around. So I appreciate your presentation today and answering all the questions and concerns. Everything was very thorough in my opinion. So I'm excited for this. I think it's a good step in the right direction for our veterans. So I appreciate both of you very much. Appreciate everything Swatch is doing in our community. And you don't have to hang out with us anymore if you don't want to.
Thank you so much
may
for
leave.
your time and conversation. Thank you.
All right. Thanks,
Bye-bye.
guys. Appreciate it. All right. Moving along. Any appeals, Mike, to discuss?
None to discuss. Looks like we only had one appeal last month, and that was approved.
Okay. And so policies and procedures, Samantha. So I guess we'll take a look at Gold Star families to see if that's a possibility to include them in eligibility or not.
Yep.
And then we can take that up with the policies committee.
Okay.
Yep.
Okay. All right. So moving along, the contractor fund reports, Samantha.
In May, the Veterans Assistance Fund served 18 veterans. The Assistance Center served way more people than that. The total bill to the fund was $10,988. There were 4 denials. We had 6 veterans totally in total this year who've exited homelessness. There were 2 in May. We served 38 men, 3 women veterans. There were 103 visits to the center with 93 meals served, 1,077 phone calls and emails, communication through the month of May, and 340 volunteer hours at the center, totaling $8,395 in value. The dental program saw 3 veterans with exams, x-rays, extractions, and restoration performed on their teeth. The value of services that were provided is $4,072, and they billed the fund for their program costs of $671. Our revenue that came in May was $86,665. The revenue that went out in expenses, $77,584, which brings our fund balance to $979,145 at the end of May. Okay.
All right. Are there any questions regarding the contractor and fund reports? All right. Veterans Assistance Center update.
Okay. So the center is now basically answering the door and the phones from 9 until 3. We are not letting anyone in at this time because we still don't have enough volunteers trained. You know, before the COVID, we had 40 volunteers, so we always had 2 people on a shift, and they could monitor coming in and going out and that sort of thing. Well, we lost a lot of them during COVID. So now we're retraining so that we have enough volunteers so that we can fully open the center and allow the veterans to come in again, but we're not there yet. So right now we are answering the phone, we're answering the door, we're passing out breakfast and lunch like usual. We're passing out toiletries, clothing, whatever they need. And we are allowing them to come into the front lobby to assist them with paperwork for the fund. Hopefully that's going to change in the next couple of months, we'll have enough volunteers trained where we can open back up from 8 until 4:30 and allow everyone in then. Our next auction online is going to be September 1st through September 14th. And if you're not on that list, if we don't have your email address, make sure we get it, because we're going to have a lot of really good items on that online auction. The stand down, as you all know, it's coming up on October 1st and 2nd. We have turned in the grant request for the stand down. And the money that you all approved, the extra money last month for the stand down items to buy for the stand down and the center, the jeans and the t-shirts, we have spent a little bit of that money already. And hopefully we thank you all for that, because hopefully we'll be able to get enough jeans and t-shirts for the stand down and the center so that we can help all of our homeless veterans. We had a visit today from Judge Parcher from the vet court, and she's terrific. We just really, really appreciated her and her enthusiasm and how anxious she is to make changes to help every single veteran, whether they're charged with a misdemeanor or a felony. Her interest is in helping the veterans, no matter how they have to do it. She really wants to help them. So we were so pleased with her, and we appreciate her and Beth Robinson coming in today. We gave them a grand tour of the center and all the things that we do here, and we spent quite a bit of time with them. So next slide. The art fund. Oops, sorry, my phone is going off. I'm trying to turn it off. The art fund grant this year was opened up to veterans organizations. It's always just been for arts, music, things like that. And this year they opened it up to veterans, and we applied and wound up getting a grant for $22,500 to assist in the center expenses. So things like water and things that the fund doesn't cover. So we were really pleased to get that. And then we had a question. In our policies and procedures, there were changes that were made to the things that we could do based on the fact that the state of Washington was in a state of emergency. Are we still in that state of emergency or not? Because if we are, we can continue to pay 6 months of different items. But if we're not, we can't. So we need to know if you all consider us still in the state of emergency declaration or not. And that's all.
Didn't they expand? I'm sorry, this is Tanya. Didn't they expand the eviction moratorium here till the end of July?
It's actually been extended through September 30th, but there are some requirements to be able to go through September 30th. Like you have to be in a rental assistance program to help pay your rent, those kind of things. But they did extend it through the 30th of September.
Right.
Okay. So I'm not sure, Kelly, somebody help me out, but I think that would mean that we could keep our program going until the state stops the emergency.
Well, that would be my understanding, as long as we're mirroring what the state's doing. Samantha, do you agree?
Yeah, I think it's going to be a real easy question to answer on whether we're still under emergency declaration or not, and I will look that up. I'll figure that out.
I can answer that for you.
Oh,
This is Sharon.
We tried to look it up today, and we were unsuccessful. We couldn't find anything that said definitively whether we were still in a state of emergency or not.
Well, I don't know about the specific word state of emergency, because after all, the state is opened up, but with the various variants out there, I mean, it could, if something happen with that, that could put us right back into, you know, something else. So I don't know, maybe maybe we need to get more clarification on that or not.
Okay.
So Tanya, or somebody, one of us probably needs to research that a little closer to, but the moratorium certainly, as far as that funding, I would think we'd be okay in that area. But if we put specifically state of emergency, then we'd probably need to revisit that.
Right.
I'll see what I can find out.
Okay, thanks.
Thanks.
That's all we have.
Okay, this Facebook post went out June 27th, has some comments on it. Is there any feedback that you can share on that or not, or?
Well,
Judy?
we basically had a couple of people recommend to us some property that someone owned, and that person doesn't want to sell. So we've reached out to a couple of people, a couple of ideas that people had, but up to this point, we've had no takers. We've had nobody talk about a building that they could donate or that we could lease from them. A lot of the buildings are either occupied or they belong to the city and the city doesn't want to release them. So we're kind of in a holding pattern where we have been for the last 18 months.
And like the post says, the parking situation, they have started construction.
Yeah.
And so the parking down here is ridiculous anymore. So if anybody's coming down here to visit, expect to have to park a little bit away.
Yeah.
So what buildings have been that the city owns? What's some of the property that could be in play there?
You're asking me to tell you off the top of my head, and I don't know,
Well,
Kelly.
yeah. So, I mean, I know it's frustrating. We're all frustrated with this because you do need more space, but I'm just thinking if the city, man, maybe I shouldn't think out loud. That's what I'm going to say next might not be received positively.
Yeah,
maybe we need to do some more research and see if we can engage the county and have the county engage the city and see if they can come to some sort of, you know, compromise or something, or I don't know. We just somehow, some way, we need to start pursuing this with a lot more gusto.
Kelly, we feel the same way. We feel exactly the same way.
Yeah,
I know, and I'm sorry that we're still at the same point. It's been super frustrating for me as well because, you know, we've been talking about this for a while, and it would be nice to have at least something to consider. Somebody, Michael, you have something? No? All right.
I'm sorry, I had a visitor come by. My mother-in-law just stopped by, so I apologize if you heard it in the background.
Okay. Now I thought you had a lead on a building, so we got excited, but never mind.
So I'll check with some people that I know.
Okay, that would be helpful.
Yeah, thank you.
All right, is that it for the center? Does anybody have any questions for Judy or Sharon? If not, we'll move on to any old business that we may need to attend to. I don't think we have anything outstanding. Any new business somebody would like to?
I do.
Okay.
Just want to put out the Portland stand down. Donna and I participate in that too, and it's October 1st. No, September. Sorry, wrong one. September 9th and 10th, right? Yeah. September 9th and 10th at the Memorial Coliseum. You know, I try to encourage our veterans to do both because they can get stuff at both places. But anyway, I just thought I'd put it out there. When I get the flyers from Roma, I'll send everybody a flyer, you know, so you have the information. They're going to have the dental van there. They're going to have some other services that would be useful. That's all.
Okay. I guess that really throws us right into open forum. So, Tanya, did you see Jim's comment about the governor proclamation?
A little bit.
All right, so I may
Oh,
do
yeah.
some research on that, see what we can come up with as far as being in a state of emergency as our policies state, and if we need to change or reword or something to that effect. All right, does anybody have anything to share in open forum?
Madam Chair, I do.
Okay.
Members in attendance, I'd like to share something real brief. I had a veteran reach out to me. She was having some difficulties, and so I called on the chair, Kelly Jones, for some assistance. And I just want to tell you, everyone in attendance, that we have some pretty damn good leadership under Kelly. She did a hell of a job in addressing the concerns of the veteran. And though we didn't get the veterans' needs met, the veteran herself was thoroughly impressed with the presence of Kelly. And I just can't thank you enough, Madam Chair, for your care to the veterans in our community and the community itself. And so I just wanted to commend you on the level of leadership that you provide and the level of care that you give our veterans.
I appreciate that, Michael. I'm still working on her case, though. I am in discussions with Liz to see maybe what we can do for her in finding some of that paperwork. There are a lot of gaps and holes to fill in the story. So, you know, we want to at least try and see what we can get for her. I mean, at least she's getting health care, so that's a positive thing. But I understand that, you know, she's probably due other things. So, well, I'm still working on it. So we don't, you know, we may not get everything we want for her, but at least she knows somebody cares. And so I appreciate you taking the time to speak with her and then calling in another old female veteran.
I didn't say old, but
to go hang out with her.
Yeah.
No, I get it though. I mean, sometimes, you know, you need that connection with somebody, and I was more than happy to make that connection with her. So
But
I
thank you.
appreciate that. Yeah. All right.
But before you ask, Madam Chair, I want to be the lone voice of dissension in saying that with the nice weather that we're having right now and the recent heat wave that we just experienced not too long ago, that we stay together a little bit, have a little kumbaya, get some marshmallows, some chocolate, and some graham crackers, have a little s'mores cookout. Anybody in agreement with me? Let's stay together.
No, Michael, don't.
I want to go outside.
Okay, that's right.
All right. And with that, I'll ask for a motion to adjourn.
So moved.
Who was that?
Ryan.
All right. A second.
Second.
All those in favor?
Aye. Yes.
All those in favor of s'mores?
Hey, if they're at your house, we're there. All right. Anybody opposed to staying?
Kelly.
Other than Michael, we know Michael's always opposed. So, all right. That's it for today. So, good work. I think the Pathways is a positive direction for our veterans and to help the center out. Everybody on this board, thanks for everything you do for veterans in our community. I'm not the only one that does that. I know you're all making contact, sometimes daily, weekly, monthly, what have you. Some of you work full-time with veterans, so I appreciate you being a part of this board. I will remind you, though, that my tenure is up in December, so somebody better be willing to step up. So my 3 years comes to an end. But please, the building issue for the center is critical. If you have any leads, let's figure out what we can do. All right. Appreciate it. Enjoy the weather. Have a good weekend, and we'll see you next month.
See you in
Bye,
person.
everybody. Thank you.
Okay. All right. Bye-bye.